Thank you so much. It's such an honor to be here. Thank you to the moderators and SAGES for the opportunity. This is my conflict of interest. It's so non-relevant, I'm not even sure what it was for. So, in this talk, I'll review the extent of the initial evaluation for newly diagnosed pancreatic neuroendocrine tumors, discuss treatment strategies for both functional and non-functional tumors, review the management of pancreatic NETs in the clinical context of genetic endocrinopathies, and cover the surgical options for management of these tumors. To begin with, some brief background information. Pancreatic neuroendocrine tumors arise from islet cells. They account for 1% to 2% of all pancreatic tumors, and non-functioning tumors account for about 80% of these. Their incidence has been increasing, as we've heard, which has actually doubled recently, and likely is a result of more frequent high-resolution imaging. Now, the types of pancreatic resections to consider include the formal resections, distal pancreatectomy and pancreaticoduodenectomy, and also the atypical resections, enucleation, and central pancreatectomies. So when identifying surgical options for patients with pancreatic NETs, it's important to differentiate tumor from cancer, to differentiate functional from non-functional, to consider the location and extent of the tumors, screen for hereditary syndromes, and also to consider, of course, the patient. So in regards to the treatment algorithms for these smaller localized pancreatic NETs, the focus of this talk, the treatment options are basically dealer's choice. They range from surveillance, as we've just heard, to more formal resections. And I'm hoping to bring some clarity to this decision in this talk. So for the initial evaluation, it really consists of high-resolution multi-phase CT scan or contrast-enhanced MRI. Somatostatin receptor or dotatate PET scans are not mandatory for staging, and they have certain limitations. They can't distinguish between small NETs and splenules, for instance, and they also may have false positivity in the head, more so than the tail, and insulinomas they're very insensitive in identifying insulinomas. It really should be used mainly to detect metastatic disease or to locate primary tumors in the setting of metastatic disease. So regarding EUS, you should only biopsy really when it adds to the diagnosis or if there's question about tumor grade. However, it is important to recognize tumor grade heterogeneity. The tumor heterogeneity often prevents accurate assessment of this, as we have previously heard as well. So EUS alone may be performed when there's a question of multifocality, as in MEN1 patients, or if it would inform your surgical strategy, but it's not necessary in all patients. So the first question is really to consider regarding surgical management of these patients is how should they be resected, meaning with an open or MIS approach. Although many prior studies comparing MIS and open surgeries in pancreatic tumors have been published, very few are only inclusive of neuroendocrine tumors, as this study by Thomas Sutton. The pooled experience of multiple regional high-volume centers was performed in patients with non-metastatic PNETs and compared outcomes between open and minimally invasive approaches, both robotic and laparoscopic. The authors found at 5 years that recurrence-free and disease-specific survival did not differ by operative approach in patients undergoing pancreaticoduodenectomy and also in distal pancreatectomy. Additionally, 5-year disease-specific survival was not significantly different by operative approach. So, in regards to the types of pancreatic NETs, should all functional tumors be resected, or and how should they be resected? So first, you need to establish the underlying biochemical diagnosis. Consider endocrinology consultation here, as this decision could be quite complex. It's essential to rule out genetic syndromes, and finally, perform proper staging to rule out metastases. But the answer is yes. A localized functional pancreatic NET without distant METs is indicated for resection. So now the question is, what should that extent of surgery be? And the answer to this question lies in the underlying risk of malignancy, which varies dependent on the type of functional tumor. It ranges from 5 to 15% in insulinoma, and from 60 to 90% for gastrinoma, glucagonoma, and other functional tumors. So for insulinomas, given their low underlying risk of malignancy, especially when small, enucleation should be considered. For other functional pancreatic neuroendocrine tumors, regional lymphadenectomy should be considered even for smaller tumors given the higher risk of malignancy. So what's the therapeutic role of lymph node dissection in these tumors, these functional tumors? Most data supporting this approach is in gastrinoma resection. This is a multi-center retrospective study that compared outcomes in patients who underwent full lymph node dissection to those with selective dissection or enucleation. They found that when resections included 10 or more lymph nodes, there was a higher rate of biochemical cure, and there was also a trend toward disease-free and overall survival. So moving on to the non-functional small pancreatic nets, the optimal surgical management of these tumors remains controversial, to say the least. This retrospective study sought to identify factors associated with improved survival in non-functioning tumors, and also to determine which lesions require resection and lymph node dissection. Of note, 94% of these patients had a formal resection. The authors found tumor size greater than 2 centimeters, predicted nodal positivity with high sensitivity, and positive lymph nodes as well as lymphovascular invasion were found 5 times more frequently in the tumors greater than 2 centimeters. So smaller tumors have a lower likelihood of lymph node involvement, but is enucleation alone adequate oncologic treatment for these smaller pancreatic nets? This study queried the US National Cancer Database to identify patients who underwent either oncologic resection or enucleation for these small tumors. In the graph on the left, they found no survival difference between patients who underwent enucleation versus formal resection, with a 5-year overall survival of 88% for both groups. And on the right, node-negative patients and those with enucleation had similar overall survival that was significantly higher than the node-positive patients. So the literature supports, oncologically speaking, enucleation for small, non-functional PNETs is safe, and that the risk of post-op pancreatic insufficiency is very low. But is the morbidity of this procedure acceptable as compared to the more standard procedures? This multi-center study used propensity score matching analysis to compare outcomes between patients who underwent enucleation versus a formal resection. And after matching, there were no differences in Clavien-Dindo complications B and C, mortality, readmission, or length of stay, although there was a higher incidence of clinically significant pancreatic fistula, both before and after matching. In this study that utilized the ACS-NSQIP database, the short-term post-op outcomes between enucleation and resection were also compared in patients with small PNETs. They found that the enucleation cohort had shorter operative time, no difference in clinically relevant pancreatic fistula, lower mortality, and shorter length of stay, but also found only 11% of the operations performed were enucleations, which may reflect an underutilization of this strategy in these patients. So now regarding some of the special context of hereditary pancreatic nets, approximately 5% of patients with pancreatic nets have a positive family history. 30 to 70% of the MEN1 population has a PNET, which are very frequently multifocal, and they also occur in 9 to 7% of von Hippel-Lindau patients. But altogether, fewer than 10% of pancreatic net patients will have an associated hereditary syndrome. So specifically regarding the MEN patients, they should all have preoperative endoscopic ultrasound assessment because multifocal disease can be missed in up to 20% of CT imaging. The localized functional pancreatic neuroendocrine tumors can be resected in patients who have an acceptably low surgical risk, and the preponderance of evidence supports removing pancreatic nets greater than 2 centimeters in size, or those with rapid growth in these patients. And the stable, non-functional tumors smaller than 1 centimeter can be safely observed if appropriate follow-up is implemented. In the MEN1 patient with multifocal disease, usually gastrinomas, a surgical approach that balances oncologic principles with the desire to preserve the pancreas is very important, as these patients are unlikely to have long-term cures. Distal pancreatectomy for body tail lesions with enucleation of any head or uncinate lesions using intraoperative ultrasound with a regional lymphadenectomy would be strongly considered, as well as ruling out duodenal disease. With this strategy, eugastroninemia can be found in up to 60% of patients in this setting. I'll skip this. So there are some limitations to this information, namely that comparison of enucleation to resection for small peanuts has not been subject to rigorous study, and formal criteria for selection of these patients have not been defined. There are really no data that indicate long-term survival is negatively impacted by close surgical margins, and hence aggressive resections to obtain wider margins is unjustified. It's the tumor biology rather than margin status that appears to determine survival. And finally, reliance on FNA biopsies are limited by tumor heterogeneity. So in summary, enucleation should be reserved for smaller tumors, the ones more likely to be benign, such as insulinomas or the smaller non-functional peanuts, and that are located 2 or more millimeters away from the main pancreatic duct. Enucleation is associated with improved endocrine and exocrine function, but likely at a cost of higher post-op pancreatic fistula. And formal resection with lymphadenectomy should be reserved for the larger tumors where there's higher risk of lymph node involvement. With finally, the trends towards improved survival with formal resections, even for smaller peanuts, has been seen and should be considered for our younger patients. Thank you so much for your time.